Hello, I'm going to be talking about osteoarthritis and hopefully provide you a overview of the epidemiology, the etiology and subsequent treatment of osteoarthritis as it stands in the UK. Osteoarthritis is a chronic progressive articular destruction of the cartilage within a joint. It is normally seen as a consequence of wear and tear, so you'll see it in the elderly population, but can occur earlier dependent on familial tendencies as well as significant biomechanical stress. So when I say this, I'm referring to primary osteoarthritis. In secondary osteoarthritis, there are three causes may potentiate your this form of osteoarthritis, which include previous joint injury, metabolic processes, and systemic disease. In previous joint injury, you need to look at sort of septic arthritis, gout, rheumatoid arthritis, seronegative arthropathies, as well as avascular necrosis and Paget's disease. In metabolic causes, you need to think about hereditary hemochromatosis, chondrocalcinosis, and acromegaly. And lastly, in systemic causes, you need to look at neuropathies, haemophilia, and hemoglobinopathies. So now that we know a bit about the causes, let's talk about exactly what happens within the joint. So in a particular joint, there will be a initiating chondrocyte injury, which results in an acute inflammatory response within the synovium. This is in the aim for preserving the joint and returning it back to normal function. And there is increased proliferation of chondrocytes and increased collagen, proteoglycans and proteases, but this to some extent does change the synovium, but if it is acute, this is short-lived. The problem arises in late OA, where there is repetitive injury which results in a persistent chronic inflammatory environment within the joint. This results in the opposite of what occurs in the acute inflammatory response, where there's actually decreased chondrocyte proliferation, reduced collagen, and there is more debris within the synovium due to loosening of the articular surface. This results in the underlying bone being exposed in the joint and can lead to the two bones sort of rubbing against each other. This rubbing against each other results in sclerosis of the calcaneus bone and can lead to the synovial fluid which is found in the compartment to leak into the bone, resulting in fibrous wall cysts, and you also will get mushroom-shaped osteophytes. So it's important to bear in mind this is a chronic process, so you can find patients who are in considerable amount of pain anywhere along this sort of disease process. So now that we've talked a bit about exactly what causes it, let's talk about the risk factors that you need to be aware of when you're looking at a patient with osteoarthritis. So age is really important, as we mentioned before, as is gender. So women are more likely to have osteoarthritis at a corresponding age compared to their male counterparts. Obesity, especially as osteoarthritis tends to affect the weight-bearing joints. You have congenital joint dysplasia, joint congruity is also really important. Hypermobility syndrome has been associated, as is occupation and trauma as well as any sports that they play. That will not only affect how early they obtain osteoarthritis in a particular joint, but exactly where that is. So it's important to document all of that. So now that we know a bit more about it, let's talk about how it presents. There's five ways that it tends to present. So nodal osteoarthritis occurs in the hands, and you get the formation of Herberdin's nodes or Bouchard's nodes in the proximal and distal interphalangeal joints respectively. This tends to only be in the hand and most commonly affects the women compared to men. Hip osteoarthritis is again more common in Caucasian women and affects the superior pole of the femur, but you can get a medial cartilage loss in certain cases. Knee osteoarthritis is also another component which affects the medial compartment in most cases, so you get a bow-shaped leg appearance, a varus formation of the lower limb. And you also get primary generalized osteoarthritis, which is nodal osteoarthritis and another variant of either the hip or the knee. And you can get erosive osteoarthritis, which is where you have subchondral cysts in that sort of pathway that we just mentioned earlier. And this tends to be more progressive and not so much painful, but it has a poorer prognostic. And so the investigation we need to do is x-rays. X-rays will tend to show a late OA as opposed to early OA where there's an initial inflammatory response. But you should also try to do CT scans, especially when you're looking at the knee, to exclude meniscal tears. And management tends to be following the analgesic ladder, so the medication or non-steroid anti-inflammatory drugs, as well as corticosteroid injections, and surgery may be permitted in certain cases, and that concludes osteoarthritis.